Very excited to move into our last webinar of our 2024 professional learning series. Welcome everybody. On the behalf of UCP, United Cerebral Palsy's Research Council, I'm very excited to be able to bring this last webinar of the series. I am Valerie Percini. I am the Vice President of Clinical Operations here at United Cerebral Palsy of Central Arizona, so here in Phoenix. I'm also the co-chair of the Research Council, and I also lead the Early Detection and Intervention Initiative, a collaborative that we have as part of a national initiative at UCP, which is why I am so excited about this topic. Because as we think about early detection for cerebral palsy, that we have to ask what's next. And I'm excited for Kelli to be here tonight to talk about baby constraint-induced movement therapy, because for a lot of our children with cerebral palsy, baby constraint-induced movement therapy is the what next for those kids with unilateral cerebral palsy. So today's presentation is in collaboration with the Research Council, but also with Gillette Children's, as well as UCP of Central Arizona. We have a lot of plans for 2025. I'm very excited. We will have a lineup of about four webinars, and there will be more information to come. But the next one is February 13th. So mark your calendars, please. So February 13th, 2025, by Dr. Michael Kruer. He'll be presenting on deep brain stimulation. So the official title here is Advances in Deep Brain Stimulation, Lighting the Way for Dyskinetic Cerebral Palsy. So again, more information to come. So a few reminders that you will see before I will just go through before I introduce Kelli officially. If your full name is not on your little screen when you've signed in, please put it in. It just helps us to be able to connect who's attending, to be able to get your continuing ed or your CMEs to you. So just to help us out there, as you may know, there are free CMEs with this webinar, and it's typically 1.5. So if you help us, we'll be able to get that email to you after the webinar. Also know that there is a short survey that we would appreciate you filling out for us for today's presentation. It helps us to be able to learn and grow from your input, and as well as make the professional learning series better. Also, there will be a link to this recording that will be sent to you later. So again, look for that, and do us a favor, share that with your friends and your colleagues so they can learn or they can benefit from the professional learning series as well. So I think that I have everything that I need to tell you before we get started. So Kelli is with us today. She is from Gillette Children's, and I'm really honored. Actually, I've been able to work with Kelli just down through years. She's part of the Early Detection and Intervention Collaborative. She has been with us for, I think, the 3 years of that journey. But what else you need to know about Kelli is she's an occupational therapist, and she works at the pediatric outpatient clinic there at Gillette Children's in St. Paul, Minnesota. She received her master's in occupational therapy at the University of Minnesota. She is a co-lead in the development of Gillette Children's Constraint-Induced Movement Therapy program, and has been involved with several research studies on constraint-induced movement therapy. She's also a co-PI of 2 of those studies. So, and she and I have talked about them. So it's amazing work. It's what we need to understand more about this topic. The current research study that she has right now focuses on infant constraint-induced movement therapy, which is what she's talking about us today. Within that study, they're using accelerometers, and we're excited to see some of the outcomes of that. And one of the reasons I actually know about it, besides the fact that Kelli and I like to talk a lot, is that Also, this grant was, I think, partially funded. I'm pretty sure it was partially funded through UCP's grant process that we roll out every March in celebration of National Cerebral Palsy Day. So I was able to read that submission ways back, but it's an amazing study. Kelli is also certified in the gold standard of upper extremity assessments for unilateral cerebral palsy, including the assisting hand assessment, or what we often call the AHA, or the mini assisting hand assessment, so the mini AHA, and the hand assessment for infants. So just really knowledgeable in this area. We're excited to have her with us tonight. Thank you, Kelli. I'm going to turn it over to you.
Okay. Thank you, Valerie. I'm happy to be here. Just gonna get my screen pulled up here. Okay. All right, so like Valerie said, we're going to talk about baby constraint-induced movement therapy. Sometimes interchangeably, I'll call it infant constraint-induced movement therapy, but we're going to talk about the essentials for evaluation and treatment. And putting this presentation together, the target audience is primarily for clinicians wanting to start, therapists, I should say, wanting to start a CIMT program for focusing on for babies. So our objectives today for that is just going to cover part of the literature, the patients with unilateral CP, and how this may benefit them and their family role. We're going to talk about the assessment process and as well as the treatment process. I don't have any disclosures or conflicts of interest. Just a request, please. The videos and photos are being used with signed consent. Please no photos of those slides with those. And I would like to thank you, Valerie, for your collaboration in the formation of this presentation, as well as sharing some of your slides that are used with your logo on them. So to start out, what is cerebral palsy? It's the most common physical disability in childhood, affecting the development of both motor and posture. And that's primarily what we are talking about today, is the motor piece of this. So there's 4 types of cerebral palsy. The majority of cases have spastic cerebral palsy, and the others are ataxic or dyskinetic, and some have a mixed presentation type. So looking at the topography of spastic cerebral palsy, there's 3 types. So there's diplegia, which is primarily where both legs are affected. The arms may be affected as well, but primarily the legs are affected. Unilateral CP or hemiplegic CP, those terms are used interchangeably, affects primarily one side of the body, of the arm and leg, and can also radiate into the mouth as well. And quadriplegia or bilateral CP is affecting both arms and legs. And in these cases, primarily the face and trunk are also affected. So the majority of cases are unilateral or hemiplegic CP at 40 to 60% of the cases. So when we're looking at the gross motor severity for children with unilateral CP, there's a gross motor classification scale called the acronym, the GMFCS. And here's a diagram looking at level 1 is from the top, and that's ambulatory without needing any help of a railing going upstairs, all the way to the other end is GMFCS 5, and that is non-ambulatory. So the kids with unilateral or hemiplegic CP, 88% of them are in the highest level of GMFCS 1. and comparing this to hand function. So the hand function scale is the max scale, and the highest max level of max level 1, only 21% of children with hemiplegia have a max level 1. So over 50% have a max level 2, and a max level 3, 22% have this. And this was just taken from a sample. I looked at 2 studies looking at the longitudinal development of hand skills. Those articles, are listed here, and that's from a sample of 336 children. So you can see where for a lot of these kids with unilateral CP, their upper extremity is more involved than lower extremity. So the presentation of children with unilateral CP has been taken from Dr. Brian Hoare from Australia, and that includes a decreased use of the more affected limb, which affects weakness and muscle tone, decreased sensory awareness. They may have cognitive involvement, and a lot of these children do at a minimum with attention. Visual involvement is about 25% of the cases. Decreased motor planning, developmental disregard, as well as behavioral changes. So now we're going to jump into the literature. And the definition of baby or infant CIMT is taken from Doctors Eliasson and Sostrand from Sweden. And this is taken from their manual called the Baby CIMT Manual. And I'm just going to read their definition. Baby CIMT is a further modification of modified constraint-induced movement therapy, or CIMT, adapted to very young babies at risk of developing unilateral CP. Its main purpose is to increase the use of the evolved hand. Baby CIMT is intended to give the child numerous practice repetitions, I bolded that, with the affected hand so that the development keeps up with that of the other hand. So the key ingredients of baby CIMT, it's very similar to regular CIMT, with the key ingredients being there's a restraint, there's intensive structured practice, and it's utilizing a motor learning theory. And for some of the older kids with CIMT, one of the theories that is used primarily from the psychology background is using a shaping versus primarily a motor learning theory. So there's been a large systematic review by Dr. Iona Novak and her colleagues. And what they looked at is all the interventions for cerebral palsy. And if you look on the left, they have divided this into what they call the traffic lights article, and green is on top, and that is that research that's been proven effective and they're recommending to do it. The yellow is uncertain, with the plus sign on top of this line right here. They're recommending to probably do it. And the yellow with a negative sign, that is probably don't do it. The red is proven ineffective and recommended not to do this treatment. And the size of the bubbles is dependent upon how much research they've looked at, or how much research has been done in that area. So I'm just highlighting in 2019, this is just the general category for CIMT, for all of CIMT. And this category is for early intervention. So that is what we're talking about today. So in 2019, that was a yellow plus sign. So still considered uncertain, but recommending to probably do it. And then the most recent systematic review we have looking at infants is by McNamara and as well as Iona Novak, who is the primary author of this study, and Dr. Catherine Morgan. And what they determined is this is just the one focusing on infants. And they used the same traffic lights, the green, the yellow plus, the yellow minus, and the red. So CIMT for infants is a yellow plus, so probably to do it. So just briefly touching upon why is CIMT effective? And there's four main theories, and that is enhanced activity in the contralateral primary somatosensory cortex, as well as the motor cortex. Can be a rebalance of the hemispheric activation, as well as potential enhanced neurogenesis after CIMT. So if you're interested in taking a diver deep into this, Dr. Darcy Failings has done a really wonderful presentation explaining all of this in one of the former UCP presentations from 22. So that leads to the question, why do we want to start in infants, and why is this been called an optimal time period? And that is because of the really important phases of sensoromotor reorganization that is happening in infants. So the cortical spinal tracts are still developing, and what helps them develop is activity. So now we're going to jump into what the main protocols are for infant CIMT. So the Swedish group, led by Dr. Ann-Christine Eliasson, her and her colleagues developed the first baby CIMT protocol in 2014. And so that was published in 2014. And then they did a research study, and it was the first randomized control trial. And they compared baby CIMT to just a sensory-based protocol or sensory-based intervention of massage therapy. And they determined that, yes, baby CIMT was certainly much more effective than massage. And the same group, then they followed up when the babies were 2 years of age, and they compared the babies that received baby CIMT versus the ones that didn't. And they found the babies that received baby CIMT, their hand function was a lot better than the babies that didn't receive baby CIMT. And their outcome measures were the hand assessment for infants, as well as the AHA. So what their protocol is putting, it's a very modified format, and it's wearing a mitten or some type of restraint, soft restraint for 30 minutes a day for approximately 12 weeks. And they divided this into a 6-week block of therapy, then a 6-week break, and then another 6 weeks of therapy. And it's really focused on self-initiated active motion. Their total dosage is approximately 36 to 42 hours. And the age range that they classify baby or infant CIMT is 3 to 18 months of age. And the other piece to note is training is done by the caregivers who are coached by occupational therapists. The other main baby CIMT protocol is from Dr. Natalie Maitre, and she is out of Atlanta and has also been involved in Ohio. And they call this the multimodal intervention, which involves baby CIMT as well. So their intervention, or I guess first I'll touch upon their research. They first published their protocol, and then they did a randomized controlled trial where they looked at babies who were just receiving play or bimanual play versus babies who were receiving their protocol, which entailed CIMT of both a direct and indirect. So the difference between direct and indirect is direct therapy is a caregiver is sitting in front of the child, really actively engaging the child, versus indirect is the child still has the soft restraint on, but is exploring their environment on their own. And then the other piece of their training involves a sensory motor piece of reach and also bimanual play. So the total dosage that they have published is 6 hours a day, and that includes both the direct and indirect. And this entails for 4 weeks. And in addition to the CIMT, they also do 20 minutes of bimanual play a day and 10 to 20 minutes of reach training, as well as 10 to 20 minutes a day of motor sensory training. And the age range they have published is 6 to 24 months of age. And they also use a soft restraint. And for some of the babies that need it, they use a sticky mitten to help with the reach training. And they also use a caregiver coaching model. And the third protocol that I've seen in the literature comes primarily out of Australia, but this was a multi-site study. So this protocol was published, I believe, in 2017, and they were hoping to get 150 babies. And what they were doing is they divided half of the babies to get baby CIMT and half of the babies to get a very specific type of bimanual training called baby like BIM. And so their total dosage is, so babies that are, I should say, I'm sorry, some of the babies started at 3 months of age, some of the babies started at 6 months of age, and some of the babies started at 9 months of age. And the CIMT group, they were restrained by a mitten or a similar soft restraint. And then the baby BIM group, they received bimanual activities that were based on the mini assisting hand assessment. And again, they also used a caregiver coaching model. And the results are about to be published in the next week or two, I believe. But essentially, they had roughly 100 babies that completed their protocol. Both groups had, of the baby CIMT versus the baby bimanual group, they had equal improvements. The babies that started at 6 months of age had better hand function scores than the ones that started at 9 months of age. And I think the other really important part to note about this is only 2/3 of the babies were diagnosed with unilateral CP at the age of 2. So this is an intervention that is being utilized not only for babies who have been diagnosed with unilateral cerebral palsy, but also who are considered at risk of unilateral cerebral palsy. And then next, I just wanted to touch upon the studies that talked about offering baby CIMT virtual, as that may be an option for us to do. So the Swedish group, they just published this not that long ago. I don't have the year in front of me, but it was within the last year. And they compared 20 babies who just had virtual therapy to 18 who were versus the in-person group. The ages were 4 to 8 months. The protocol was exactly the same. And the results showed equal improvements on their main outcome measure was the hand assessment for infants. And both options were received really well by the caregivers versus the multimodal group. They published their protocol and study in 2020, so the era of COVID, and they had 7 babies who received virtual versus 6 that were on the wait list, and compared them, and their ages were 6 to 24 months. And they did a similar protocol where the baby CIMT was 6 hours a day of both indirect for 5 days a week. and they had 1 in-person visit and 3 telehealth visits. So I think that was less than what their typical protocol was. And they did not find any improvements. Their main outcome measures in all their studies are the kinematics of smoothness of reach, as well as the fine motor section of the Bailey. So with their virtual, it was different where they didn't really see a difference between both groups versus their in-person, they had seen a significant improvement in their reach. And the same thing with the fine motor scales. So with the virtual, they also noted, or they noted that those babies did improve their fine motor scale from the Bailey. And they just concluded it was feasible and potentially effective, but they wanted to do a larger study. So just recapping the two main models of infant or baby CIMT. It's the Swedish model, which and they collaborate very closely with the Australia group. There's also a group in Canada that practices their model. And this is comparing it to the multimodal model that's in the US. So the dosage for the Swedish model is in total of roughly 42 hours of CIMT, and that is just of direct CIMT. And these babies, they also do bimanual therapy, but they consider that separate. And versus the multimodal group, their dosage is significantly higher for total hours of CIMT, but the direct CIMT is about half of what the Swedish model is, but the indirect is significantly more. So again, that's where the babies have the restraint on, but they don't actively have someone in front of them guiding their very specific training. And then the multimodal also includes in their training roughly in total 9 hours of bimanual therapy, 4.5 hours of reach training, and 4.5 hours of active motor sensory training. They both utilize a coaching model. The ages for the Swedish model, they start a little younger at 3 months of age and usually go until 18 months. Versus a multimodal, I think the majority of their babies are at least 6 months, if not 9 months and older, through 24 months of age. And so the daily practice hours are quite a bit different. And the Swedish model would be considered a distributed model. So that's kind of similar to what we would do in a standard episode of care for what a home program would be. Roughly 20 to 40 minutes a day, or I should say this is more than a typical, but kind of a typical home program that it would last over like 12 to 18 weeks. Versus the multimodal, that's really intensive. It's mass practice, and it's over a shorter time period of 4 weeks. The Swedish model, they do multiple blocks of therapy, versus the multimodal, they do 1 episode of care. And there's one piece I forgot to mention about the multimodal group. For one of their outcome measures was they were looking at the sensory component of, does this training, in addition, this CIMT plus bimanual plus the motor sensory training, does that impact their sensation? And they showed it does. And I think that's a really important point to highlight about their method. So just giving an overview of what are the components of infant or baby CIMT. So the ages can start from as young as 3 months of age up to 18 to 24 months. The dosage is roughly 42 hours. And I just combine that for direct and indirect. And that can range from 30 to 60 plus minutes a day, 5 to 7 days a week, anywhere from 4 to 12 weeks. It's really focusing on its active motor training. It's not any passive motion, and it's repetitive motor training. The non or less affected hand is restrained by a soft restraint. The baby is in an upright position, and it's has been utilized by using a caregiver coaching model. So the majority of the therapy happens in the home. And the other pieces is to make sure it's a just right challenge and a positive experience for the baby. So now we're going to jump into the assessment section. So the candidates to consider who would benefit from baby CIMT, and this comes from Dr. Anne Christine Eliason and her colleagues, as well as Dr. Brian Hoare. And it's for any babies that are at risk or are diagnosed with unilateral cerebral palsy, that they present with an early hand preference. And this can show up as early as 3 to 5 months of age. And they're demonstrating an asymmetry. And for both of them, they utilize the hand assessment for infants as well as the Hein. And we'll talk about that in a couple minutes. The ages are between 3 and 18, and some, like I said, go up to 24 months of age that consider it baby CIMT. They have unimanual goals to increase their capacity for using their affected hand. They have some selective motor control. They have stable health. They have visual attention. And the caregivers had the bandwidth to do this program, as most of it is done in the home. So this slide is just giving an overview. In the ideal world, if you're able to do baby CIMT assessment, these are the components that would all go into it. So it's ideal if you can look at their unimanual performance, their bimanual performance, if you can do a developmental assessment or screen, just to make sure that we're not missing something from a developmental standpoint, not only within our scope, but also just being mindful of our PT and speech colleagues. Going over the caregiver goals, being aware if they have awareness of their upper extremity, and if they're 12 months and older, we can utilize a classification scale. So diving deeper into these, the unimanual assessment options that have been utilized is the hand assessment for infants, and we'll talk a little bit more about that in the next slide. The Hammersmith Infant Neurological Examination, or the Hein, and they give an asymmetry score, and we'll also talk about that in a couple minutes. The Bailey Fine Motor Assessment, looking at the unilateral, as well as the Earhart Developmental Prehension Assessment. So going deeper into the hand assessment for infants, I do think this is the gold standard outcome measure, because this gives both a score for unimanual as well as bimanual, and it also gives an asymmetry score. And this has also been utilized, I believe, in Sweden and Australia to help in the diagnosis for babies with unilateral cerebral palsy. Other benefits of this assessment, it's valid and reliable. It gives age norms. It can help monitor hand development. And another piece about this assessment is it's videoed so that you can go back and you can score it, because when you're giving the assessment, there's just no way that you could score the assessment and give it at the same time. And this is for babies ages 3 to 12 months of age. And there is also a hand assessment for infant screener. And this training is free and it's self-paced. This is online. And what you will learn in this training is how to provide a 5-minute video recorded play session. And it's taking, I haven't taken the training, but I'm not sure if it takes part of the pieces from the high or if they're a little bit different. But there's 6 items that you would be looking at with this. This is for the same age ranges of 3.5 months to 12 months of age. And if you're interested in this, you can look at the Manual Abilities Classification System website or the MACS website, and I have that listed here if you're interested in that. And if you are, there's a QR code that you just click into, and then that brings you to an email that you can sign up for that. So the HINE, or the Hammersmith Infant Neurological Examination, if you're not familiar with it, it's a neurological examination that assesses motor and neurological function. This also helps assist in the this assists in the diagnosis of cerebral palsy. This is from the age ranges is from 3 months to 24 months. And what is really beneficial for this population, in addition to looking at their overall neurological function, but is also giving a symmetry score. And that's what we really want to see, is who would benefit from this. And if they're showing an asymmetry, then those are the kids that we're wanting to do this protocol with. So the bimanual assessment for this age range from 8 months to 18 months is the mini assisting hand assessment, or the mini AHA. And this is from the same family, from the hand assessment for infants, the mini assisting hand assessment, and then after the ages of 18 months, there's an assisting hand assessment, or the AHA. And this is also video recorded so that you can give the assessment and then you can go back and score it. This is valid and reliable. And the primary focus of this is just measuring how the affected hand is used with bimanual activities. And another piece of this that is incredibly helpful for treatment planning is it provides a hierarchy. So from here, it's listed as easy items. So the first items from a bimanual standpoint is holding, then contact with objects, then grasping from an easy position, then stabilizing by weight or support, and amount of use, how much they move their arm, finger, and then getting into using their grasp as a stabilizer, etc. And then the hardest item is bimanual manipulation. And then developmental assessments. The first one I'm just going to highlight is the Day C, because this gives a predictive quality of CP after 5 months of age. And this has 5 domains, including cognition, both expressive and receptive communication, social emotional skills, gross and fine motor skills, and adaptive behavior or self-help skills. Other developmental assessments or screens for this population is the Bailey, the Infant Motor Activity Log, or the IML, the Pediatric Evaluation of Disability Inventory, or the PD, as well as the P-Body. When developing goals, these are the 2 measures that have been listed in the literature for this population. So the COPM, or the Canadian Occupational Performance Measure, or the Goal Attainment Scale. So unilateral, just looking at their overall awareness, is just seeing, are they aware of their affected side, and how do they respond to touch and temperature and pain. So lastly, we're just going to briefly touch upon the classification scale. So beginning at 12 months of age is the Mini Manual Abilities Classification Scale, or the Mini Max. And this has been developed from the Swedish group, Dr. Eliasson and colleagues. And what this is looking at is really, how does a child function with everyday objects using both hands? And this is determined by a caregiver with the therapist guidance. So now we're going to jump into treatment and just highlighting using a caregiver coaching model. So this is a review that was done in 2022 and in AJOT, and what they determined is coaching is a viable option, and they're recommending more studies. I'm familiar with two coaching models. The first one is Teach Back. And if you're not familiar with that, what that is that you will demonstrate what you're wanting the caregiver, or if the child is old enough, but in this case, the child is so young, you demonstrate what you want the child to do or the caregiver to learn to have the child do. And then you have the caregiver demonstrate that back to you, ideally, if they can. If can't, then verbalizing it. And then also utilizing this model for follow-up treatment sessions. So I'll have parents bring in videos from home, and also in sessions, they'll just demonstrate it. Another coaching model that I use is motivational interviewing, and this comes out of the psychology or mental health field. And basically what this is this is just a guided style of communication, really trying to empower the caregiver to find meaning and really develop this of how this will work in their life. And it's really about a collaborative partnership and highlighting the caregiver's strengths and really what's working for them. So when we're starting to look at what treatments to do, we want to make sure we're being mindful about their typical development. And Dr. Sue Greaves, during the hand assessment for infant workshops, really highlighted we want to make sure we're mindful of their vision and cognition when we're looking at their hand skills. So here I just put together a slide highlighting typical hand development that I learned and was highlighted during the hand assessment for infant workshop. So between 3 and 4 months of age, the baby is starting to reach and have hands at midline up to 5 months of age. 5 months of age, they're also can be beginning to transfer a toy up to 7 months of age. Starting to explore a toy between 5 to 7 months of age. Their grasp pattern begins at about 6 months of age. Their grasp pattern further develops at 7 months of age, and 8 to 12 months of age. You just see more of a pinch pattern developing, a purposeful release, smoother transition of transferring of skills, banging two objects together, and the pulling and pushing. The pulling motion. And then just typical development for play skills is from 3 to 5 months of age. They're starting to mouth objects, examining them. They're starting to use their fingers. 5 to 7 months of age, they're shaking, banging, continuing to mouth toys, squeeze them, tear them. They're interested in peekaboo and looking in the mirror. And 8 to 12 months of age, starting to do container play, a lot more exploration of toys, of pulling apart and imitating. So getting into the specific constraint options, this is a combination of what's been listed that I've seen in the literature, is just like their sock, a little teether mitten. I've tried that with a patient and just taken off the teether portion of it, just a commercially available mitten. Or I've also utilized this soft mitten here. The group from the multimodal group, they have a specific pattern that they suggest using. So, a couple guides that have been helpful for me that I thought would be helpful for you if you're just starting out a baby CIMT program is that I just want to highlight. So, the first one is the main one that I've been using, and it's a baby CIMT manual that I mentioned before. And this has been developed in Sweden at the Karolinska Institute by Doctors Ann-Christina Eliasson and Dr. Lena Sorstrand. And this is available on Dr. Ann-Christina Eliasson's page on the Karolinska Institute. However, I just contacted her to say, hey, I wasn't able to find it. And she said their website is in the process of being updated. But once that is done, you should be able to access this manual there. And one thing I just want to note, this does have an international copyright. So if you get it and you want to share any of the information from it, you just have to contact them for permission to see if they're okay with that. So I just want to highlight something that I think would be really helpful to point out is they determined there's 3 levels of hand skills that we can work on in baby CIMT. So the typical development is reaching and pre-grasping or holding at 3 to 4 months of age. The second level that comes is grasping, and that's at 5 to 7 months of age, typical development. And the third level is object manipulation that develops at 8 to 12 months of age. The other piece that I really wanted to highlight about their manual is they have these treatment guides, and what they do, which I have highlighted here, where they list, okay, so this is for the first level. So this is reaching and pre-grasping or holding. So they say, okay, what does the child do? So initiates reaching towards an object by touching, moving, and sweeping them from a close position. Then what the therapist or the caregiver does is shows the object and holds it near the baby's hand within their visual fields. And then toys that you can utilize for this. So they have these treatment guides for each of their 3 levels that are in their manual that I have found extremely helpful. Another tool I thought would be helpful for you is on the Holland Bloorview Kids Rehab Hospital website. They have some really helpful resources. So they've basically taken the Swedish model's baby CIMT, and they've taken it a step further and developed a handbook and also an interactive tool to help with treatment planning. And there were 14 medical professionals across 10 institutions in Canada that have come up with this. And I reached out to one of the primary authors and asked if this is open to all of us, and it is. They're happy to share it. So I'm just taking a snippet of what is in their manual. So they have tips for when to do baby CIMT at home, which they highlight. Choose a time when the infant can play, when you are uninterrupted as the caregiver, and when the baby is fed, alert, their diaper is changed, and there will be very minimal distractions. And then you just need to click in the rest of them for tips for positioning, for playing, the restraint, and then bimanual skills. And then their interactive tool, they take it even a step further. And I'm just highlighting. So these are target movements for baby CIMT. So they have shoulder flexion or elevation with reach. They have elbow extension, holding, supination, wrist extension, grasp and release, and more of a refined grasp and release. So when you're on their website, you can pick an item. So here I just picked reach. I picked the difficulty level medium, and then I picked common items that are in the home. And then this is what you get, and it looks like it can be printed, and that then you can use this as a home program. So that is listed on the Holland Bloorview Kids Rehab site. And when you get to their website, you can just type in baby CIMT and these resources will pop up. The last piece I wanted to highlight is they have an essentials page that just goes over the components of constraint, which we have talked about already, but this is in a nice diagram that I thought you might like to see. So I'm just going to briefly share from my experience how I've used the baby CIMT manual. For the first level is beginning placing objects close to the hand and how I've progressed that. So how long they can reach, how far they can reach, using functional cause and effect by either spinning a toy or hitting a switch toy, knocking down a tower of blocks, making a necklace move, hand motions is doing high fives and touchdown. So I have a video to show of a mother doing a really great job of utilizing baby CIMT at home. So you can see that this is really challenging for him and he needs extra time and encouragement to get these additional reps in. So the caregiver is sitting right in front of him. He's in a supportive chair. The tray is at like belly button height. His feet are supported on the floor. Mom is continuously giving him tactile input. And they're both having fun. We blurred his face out, but he was smiling throughout it. The second one is grasping. So this isn't the ideal shape for him to be grasping, but that is the shape that we had. So this is just a teeter wafer. A rounder shape would have been easier for him. I should say more of like a cylinder shape. So I'm pulling it out to get more reps for him grasping. The other part of treatment that I think is important is sensory awareness and input. So sitting on their affected side, which was highlighted in the baby CIMT manual. In the multimodal model, they recommend dry textured bins and doing active movement in that. I have done that and think that's beneficial. Providing tactile input, vibration, wet, messy play. And then just the importance of caregiver education and the environmental setup. So the environment is enriched. And making sure you're utilizing the coaching model to help the caregiver prepare for their therapy sessions and also how to progress through them. And lastly, with treatment, I just want to highlight the importance of bimanual skills training. Sometimes when families come in, they say, you know, I really want my baby, I really want their right hand is affected, I want them to be right-handed. Once they're diagnosed with unilateral cerebral palsy, or I should say, I've never seen a child who their affected hand has been their dominant hand, that it's usually been their helper hand. And the goal with our training is also with the bimanual training is how do we have their affected hand be the best helper hand it can be? I just want to touch upon a couple studies that talk about hand development. And the first one is from Dr. Leanne, Dr. Leanne Sazetsky. Hopefully I'm saying that correctly. But what she and her colleagues did is they looked at roughly 100 babies beginning at ages 3 months through 12 months and discovered there's three main trajectories. So there's babies that have low function, babies that had moderate function, and some that had higher function. And with the low functioning ones, which may realistically be a lot of the babies we end up seeing because those are the ones that are caught early, is a lot of those babies didn't make a lot of progress the first 12 months of age. And this ties into the second study I wanted to highlight. And I learned of this from Dr. Hoare, Brian Hoare, at a course that I just attended. But this work comes out of Sweden. And really, they looked at the longitudinal development of hand use with babies, and they were going by the max level, so their classification level. And for max level 1, so the highest level, those babies hit 90% of their hand skills by 2.5 to 3 years of age, versus max level 2, they didn't develop their maximum hand skills until 3.5 to 4 years of age. And max level 3, they didn't develop their max hand skills until roughly 4.5 to 7.5 years of age. So I think that's helpful when we're thinking of, okay, these babies, if we see a baby and we think, gosh, you know what, I've been doing baby CIMT for 3 months and they didn't make a lot of changes, that they're just needing a longer time period to make those gains. So now I'm going to go over a case study. And I just kindly ask you to not take any photos of any of the images. And I just want to thank this family for generously sharing their story with us. They're really passionate about having other children receive the same level of care that their child has received. So this child was born at 37 weeks. His APGARs were good, breathing was good. He did not need a NICU stay. At 4 months of age, parents noticed a hand dominance. And so at their 4-month pediatrician visit, they brought this up, and the pediatrician was also concerned and referred him to our brachial plexus clinic. In our brachial plexus clinic, we have a neurologist who saw him and did an MRI and diagnosed him with an MCA stroke that happened in utero. And he also saw OT and PT at 5 months of age, speech therapy at 6 months of age, and PM&R at 7 months of age. So when he first started, this is what his hand skill looked like. So this is part of the hand assessment for infants. Makes a little bit of contact. Not a lot. I am about to place this in his hand. I'm seeing how well he can hold the toy. And he holds it for a couple minutes and then grabs it to the other hand. So this is when he was 6 months of age. His treatment included baby CIMT, bimanual therapy, sensory input, collaborated very closely with speech, working on cognition, and also worked very closely with PT, home program, and I should say cognition and language. And he's been seen quite a bit. So roughly weekly from around 6.5 months of age to 18 months of age. And we're planning to see him until he's fully ambulatory. So he is involved in a research study. So we are tracking how many hours he has done baby CIMT, which is 86. He did it roughly 30 minutes a day or as tolerated. We really worked on enriching his environment. And primarily we're focusing on level 1 and level 2 from the baby CIMT manual. And he was primarily motivated by food and some toys. So his therapy focused on a lot during snack time and sensory input. So this is what he looked like after 3 months of age. I'm sorry, after 3 months of baby CIMT. So you can see he's reaching better. Dad's prompting him a little bit. But his hands started opening up and started getting more reaching reps in. For his bimanual skills, we're really following the mini AHA, and it's been fun to see how this has expanded. We first started just with holding. And so that's when we started doing bimanual therapy, is when he was showing the capacity to hold objects in his hand. So we're working on all of these that are highlighted: contact with objects, grasping an easy to grasp object, stabilizing with support, the amount of use, moving his arm, his fingers, and now we're really focusing on stabilizing by grasp. So he's done roughly 30 hours of bimanual therapy. We're also utilizing baby sign language. It's been really fun to team closely with speech therapy. So this family has been very dedicated and devoted, and there's multiple caregivers that are sharing the therapy burden. They're a family that they want as much therapy as they can get. They're finding it really beneficial. And the family has been really wonderful, that they're very mindful of, yep, we are only going to do this when he's at his peak. They've really enriched their environment. They've incorporated a lot of his therapy just into their daily routine. And so here are some photos taken a couple months ago. So you can see he's holding much better. He had grasped for this necklace on his own and is holding it really well. This one, he was spontaneously doing this. And if he wasn't blurred, you could see how just delightful he is. He was laughing and he's dancing. He's just really, he's incorporating his right hand into play so much better. And this is mom, who I think she was destined to be a therapist. She's such a natural at it. So she's sitting in front of him, encouraging him. And I believe this is our last video. I'm just going to play this one more time because I think, you know, when we're looking at this, it's important to note he's interested, he stays with it, he can pull it apart. When he can't get it back together, he loses interest. And I think that's really to highlight, you know, what can be so challenging for our job as therapists is having the right toys and equipment to help these kids develop their hand skills. So that is it. We will open it up for questions.
Oh, thank you, Kelly. That was phenomenal. I just have to say, I am an occupational therapist, and you read through the literature, and there's so much out there, and you just brought it all together. You just compiled it all together, and I think it's so helpful because when you're in the clinic, all of this, there's protocols, different protocols, and so to see it there on the screen and just be just those comparisons is so helpful in navigating, the information that's out there for the clinician that is in the day-to-day thick of it with families. So Maya, could you expand a little bit on the two coaching models I just have a question. And, I've
Oh,
talked about
sure.
this a little bit, but I have a question is the two coaching models that you presented. Um,
Mhm.
can you tell us more about it? Like, why did you like them? What did you find to be beneficial? You touched on it a little bit, but can you expand on it?
Yeah, I can. Do you want me to go back to that slide so it's
Yes,
up?
that would be amazing. Yes, because I can't
Okay.
recall the names of them.
Yeah, and I'm just gonna see how to do this just quickly.
Yes, perfect.
Yeah, so the teach back model, this is a model that I believe comes out of the nursing literature or field. And this was presented to, I believe, all of us clinicians at Gillette. And it was quite a few years ago. And really making sure when we're educating caregivers or patients that they're understanding what we're saying, that it's not just us demonstrating and then saying, okay, then just go home and do it. And I think we've all probably been on that side as patients where we might get home and we think, okay, now what was I supposed to do? Or what did they say? And so what this is just really helpful to help engage in this for the caregivers, engage the caregivers. So it's not just us doing the therapy. So much of this is I think what's really effective is if we can demonstrate it and then primarily be coaching the caregiver to be the one engaging with the child, the one doing the therapy in front of us, and then us using more of a coaching model versus they come to therapy, we do all the therapy, and they sit there and watch us and then go home and do it. And I think that just it helps with that regard of trying to look at it in that vein. And then the other piece, the motivational interviewing, I think so much of this is it's really trying to think of, okay, how can we partner really well with them? And I think it's, at least for me, it's easy to say, go home and do this.
Mhm.
It's another to walk beside them and really help them to determine, is this even feasible right now? If it's not, what are the barriers? And to help them determine if we can kind of problem solve through that together and really be with them, because I think every family that comes in, they want to do the best for their child, but some just have so many other stressors or demands on their time. And I think if we can be utilizing like a lot of open-ended questions and reflecting back to them, okay, this is what's important to you, and then helping them navigate that of, like, an example is, oh, you're telling me your child really isn't interested in toys, but they're interested in food. Is that feasible for you to do the therapy during mealtime? Well, if there's other children, it really isn't. They'll
Mhm.
say, no, mealtime is incredibly stressful. I'm making a meal. I have hungry children. I can't do it. So it's trying to help them determine, okay, when is the best time for you? When is the best time for your child? And just trying to be really collaborative.
I love that. And it kind of feeds into a question that Katie kind of puts into there is, do you have any advice? This is in the Q&A. Do you have any
Mm-hmm.
advice for working with families that encounter, you know, regular dysfunction, missing appointments, and struggle with following through with home programs. Is some of this help with those things that Katie brings, brings up in this question?
Yeah, I think that's a good point, and I think we all have had those families. And I think the motivational interviewing comes in really helpful in those cases. And it might be this just simply isn't the right time for them. Or, I think we all have seen there's different bandwidths that families have, whether it's demands or whether it's just challenges to get to appointments or it's challenging to do the therapy. Um, as our time allows, we really try to team with birth to 3 teams, but I know realistically we all just have very limits on our time of when we can do that. But
Yeah,
yes,
it's a
I
struggle.
wish there was an easy solution. Yeah.
Yeah.
Mm-hmm.
So Jana asked, do you use cell phones for your videos? So I think that's going back to the assessment.
Oh, no, we do not use cell phones. We use, well, we used to use video recorders and now we're updated to iPads. Mhm.
Okay. Yes, I remember those days. Um, so Julie asked, first of all, she says thank you, and yes. Would you consider a soft neoprene splint at any point towards the end of CIMT or in between, or would you rather keep the surface of the affected hand uncovered? That's a hot topic. That's a great question.
Yeah. So I'm not sure if
Do you want me to read it again?
yes, can you
Because it
repeat
was
that? Yeah.
okay. Yeah, it was okay. Would you consider a soft neoprene splint at any point towards the end of CIMT or in between? Or would you just rather keep the surface of the affected hand uncovered? So the use of the Bennick splints.
Oh, I see. With CIMT.
Yeah, I mean, do you incorporate it into
Yes. I
CIMT
say. Yes, I'm
or
sorry.
yeah,
I was picturing like a full mitten.
yeah.
Yes. So I think if you can get this is my opinion, but I think if you can get active movement, that's great to get the reps in. And and I should say this isn't just my opinion. I think the Australia Swedish group has voiced this too. But I think my experience has been if you need to, like if it's a child that their thumb is just so tucked in their palm, there's no way it's coming out. Then I find the McKee splints are better than the Bennex. Those are the two main ones that we have. The McKee is just smaller, so they have more of their palm surface to open. You can get a better position for their thumb. But at least in the first year, my opinion is I really want them to try to get as much active movement as they can. I know the Australia group, they're looking at a study of using splints, but to my knowledge, that's not been published yet.
So Kelly, you're saying age makes a difference on what, like under a year would make a difference on what you would do
That's
in
what
terms of
I've
the
done.
splints.
I just think,
Mhm.
gosh, if they have any chance of getting active movement, I really want to utilize that
Yeah.
versus when the splint is on, I just don't see kids have any ability to get active movement. It keeps it out, but then we're not actively training it. So I've also utilized, well, let's do both. When they're actively in their training with the caregiver, which is primarily the direct therapy, to not have it on if they can get their thumb open, but when they can't, to have them wear the thumb to use with function.
Yeah. I think that I mean, the benefit I think could be, you want restrictions setting up in the web space because the thumb's there. So I totally. Okay, so Janet asked, she goes, she mainly works in early intervention now. So any advice on getting parents on board? That is actually a hard one. And to all the things that you just pointed out and
Mm-hmm.
um, but if the baby is really showing like a strong, propensity towards unilateral skills, how do you get them on board? Like, like in fact, can I just add to this? Like, how do
Sure.
you explain what CIMT is to a parent, which I think could be a tool for getting them on board?
Hmm. Yeah, I've learned from the baby CIMT manual where they talk about, well, you sit down with a caregiver and you go over these are the reasons why this is recommended. And I found that really helpful. And Dr. Brian Hoare has recommended let's use the term optimal time for them to use this, which I really like, versus critical time. And I think if you can share what the research is showing, is that this is an optimal time for your baby to develop their hand skills. This is a tool we can use to help them do that. That that is the approach that I've used. And I think most of the families I've recommended have been able to do this. There's one that I haven't, myself and other colleagues too. And I couldn't, like, we couldn't figure out, they're like really devoted parents. They would come to therapy, but we couldn't understand why they weren't carrying over the therapy at home. And what we discovered after the fact was it was so painful for the mother to see their child's hand restrained and to work through that initial level of frustration. So when the child was with us, we could engage the child with toys. We had the parents engaging the child with toys. We just made the assumption that that's what they could do, that same thing at home. But we learned, that was just, I think it's not that they didn't try, but I think that's where the coaching and probably virtual sessions would have been much more beneficial. So I think it's tricky, but my experience for the most part is most families have been on board.
Okay, so another question is they have a client that has lower limb constraints as they have had um, oh, it moved on me. Transverse militias. I understand this session is on upper limb and hand function. Do you think it's acceptable to trial CIMT to increase function in lower limbs? Okay.
That's a good question. I've never done it. I want to say there's one study that has looked at it, and I can't remember any of the details of it. I think it was a case study, but I do
Yeah.
know I received GMA training, and our instructor tried it with a child and had some luck with it, but I can't tell you to do it or not do it,
Yeah.
unfortunately. And especially for transverse myelitis, I'm definitely, that's out of my scope.
Okay. Um, Also, okay, and I agree with you. I don't think there's just really any strong literature out there, right? I think
Hmm.
for sure.
It's an
Okay.
interesting concept, but
Yes, yes. Okay, so Theo wanted to know, how do you determine if an infant would benefit from CIMT versus bimanual therapy? Or is it best to be multimodal?
that's a great question. And I think within the next month or two, Doctors Brian Hoare and Sue Greaves are going to be publishing a study talking about this. Um, but I am I am not the expert to determine this. What we're doing now is that the babies receive both. I think there's so much more to bimanual training than just bimanual play. And I think it's one of those concepts is the more I learn about it, the more I realize what I don't know about it and that I want to learn more about it. And there's additional bimanual training that I think is going to be offered in 2025 or 2026. But I'm not unfortunately the one to tell you. I think in essence, it's like, well, if you want to work on one-handed skills, building their capacity, that's the term that's used, you do CIMT. If you want to work on just specific bimanual skills, you do bimanual training. But I think there's more to it than us just doing, bimanual. I think what we know as OTs or PTs for bimanual training, I think there's more to it that would be really beneficial to learn more about.
All right, we have one last question that we can sneak in before, and then we'll have to wrap it up, is because we're almost there. I mean, I knew this is a great topic. Do you ever incorporate Bennett splints while doing the program or afterwards to assist with alignment or stability to complete activities? To assist with alignment or stability to complete activities.
In babies, I do not. And I think that's the same. I mean, I definitely don't use Bennex in babies. I do resting hand splints for nights and rest time. For older kids with the Bennex splints, I find for some kids it really helps their function. Other kids it can get in the way of function. So I try it and say, and then I'll try specific activities with them if it's helpful, if it helps their function, great. If not, because I think that's really, really the heart of it is we want them to be really functional. And if we're focusing on alignment when they could be actively using it, I see that as a tool that's actually getting in the way. So I think if it can help, great. Then definitely using that. And then if we could get alignment, that's wonderful. But otherwise, I try to work on the alignment during nights and naps.
Yeah, I think as therapists, we want it to look pretty, and really, in all honesty, we have to put function. I like that. I've heard people say putting function over form, and I think it's important. Although form is important, but clearly we want our kids to be able to participate in real world activities, and function is very important. Thank you, Kelli. This is great information. Thank you for being willing to take the questions and for your time. This has been an amazing presentation. So just to our audience, I just want to remind you, you will get a follow-up email. So please fill out that survey, which I already said the why behind that. Also that you'll get a link to this recording, and please share it with friends. And then one more reminder, February 13th, that's our first webinar for 2025, and it'll be on deep brain stimulation by definitely a national expert, Dr. Michael Kruer. And also remember that you're eligible for CMEs. So, help us out. Make sure, I appreciate there are some people in the Q&A that basically said, here's my name, because I can tell it's not right on my screen. So if you also have any questions, you can always go ahead and email to research@ucp.org, and we can help you out. And just thank you all for joining us. I know we're coming up on a busy season, so have a joyful holidays. Enjoy it with your friends and families. And thanks again, Kelli. It's been amazing. All right. Have a good evening, everyone.